reproductive disorders is a little more involved than the male reproductive disorders. There's more things that we have to cover here. I will be taking this from the first slide all the way up to endometriosis, which is slide 15-7 or something like that. Okay.
So 1
through 57.
So everything.
Pretty much, except for cancer. Now, the first thing that we're going to talk about, there are a lot of terminology that we have to go over in the beginning, and so we're going to start with menstrual disorders. With menstrual disorders, please make sure you know the name of the disorder and what it is, okay? And then we'll go over some of the causes. With these disorders, they don't give much treatment options for them because it all depends on what the cause is. You have to treat the cause really and not the dysmenorrhea, amenorrhea. So we will go into each and every one. Okay, so the first one that we're going to go over is what is called amenorrhea. A meaning absence, menorrhea for menses. Okay, so this is going to be absence or suppression of menstruation. There are a number of causes from this. Please keep in mind that it can be, they say stress can do this. Hormonal disturbances, which will go into detail how the hormones actually get suppressed. And there are a lot of different causes that cause the suppression of the actual hormone. Please understand, and going back to physiology or anatomy, I'm not sure which class you guys went over this, but when the menstruation first starts in the female, please keep in mind that the hormones are elevated. So estrogen, progesterone are elevated at the beginning of menses. Once it starts, say maybe day 2 or 3 of the cycle, the menstrual cycle, then the hormones actually decrease. But what happens here is that you need that increase of the hormones in order to start the actual menstruation. If those hormones are not elevated, then the menstruation will not happen. Okay, so please understand that this is a hormonal thing. And so what happens is if the hormones get suppressed, okay, or not produced, then the whole menstruation won't happen. Therefore, leading this person into an absence or suppression of the menstruation. They say neoplasias can also do this, so obviously, yes, if there are certain tumors, okay, ovarian tumors or any type of reproductive tumor, can also offset the hormone level, okay? Now, please understand too, well, I'll go into that in a second. Treatment is aimed at the underlying cause, hormonal supplementation, okay, so as most females in the class know that yes, sometimes birth control pills are given to have the cycle regular or to bring it out or what have you, because again, this is a hormonal situation. In surgery, if it is a tumor situation. Now, hypothalamus. Hypothalamus, please keep in mind, is extremely important here. And what sometimes people do forget, and we have to go back to physiology, okay, with this. Hypothalamus will secrete its particular hormones that are now going to attack the pituitary gland. Pituitary gland will then secrete FSH and LH. Does this sound familiar? FSH and LH, when they are secreted, they will also secrete estrogen and progesterone in the female. Please understand that LH and FSH have a direct relationship to estrogen and progesterone. So when LH and FSH is increased, progesterone and estrogen is increased. When LH and FSH is decreased, estrogen and progesterone is decreased. So the whole point of me saying that is so you'll understand that the pituitary gland is extremely important with the secretion of these sex hormones. Okay, so we all know, yes, ovaries and all that, but it's not just from the ovary, it starts in the brain. So hypothalamus, sometimes there are certain things that can suppress the actual hypothalamus secretion, okay, of these hormones, or the beginning, which they have here, anorexia nervosa. So when these patients do have the psychological anorexia, okay, not the physiological anorexia, because that's something different. The psychological format of anorexia, this can cause a suppression of those hormones in the brain, which will then not release or cause a absence of the release of the hormones in the reproductive system. Strenuous exercise also does that, okay? I'm quite sure you guys know this, and I have a niece that's having this situation. I actually went to school with a bunch of girls, okay, that had this situation as well, where people exercise, athletes, okay? female athletes that are very athletic and work out a lot and every day and they're training very hard, they do have an absence of menstruation. Not everyone, but that is common. Has anybody ever heard of that? Okay. So what happens with that, with these females that do exercise a lot and have this type of activity, what happens is that they have very little body fat. So when they exercise a lot, they have very little body fat. So what happens is that the body then now pays attention to, well, we don't have as much body fat as a female should, because females are supposed to have more body fat than men. Okay, and one of the reasons for storage and all that, but the other reason too, we need that fat for reproductive health. So what will happen is that when the body recognizes that there is not enough fat, it'll keep the fat that it has, try to focus on the storage and storing energy, and therefore it will suppress the hormone release from the brain. So because it's so busy focusing on the metabolism that it's not paying attention to, or the signal gets lost somehow, where it's not releasing the hormone coming from the hypothalamus and pituitary. Gonadotropin releasing hormone deficiency, okay, again going back to hypothalamus, pituitary, congenital defects, and tumors. Okay. Pituitary, we already talked about a little bit. Keep in mind that the pituitary is extremely important, as we know, with secreting FSH and LH, okay? And without that, you can't secrete estrogen or progesterone, and even testosterone for that matter, okay? So if any problem with the pituitary, that will cause an issue. And the thyroid, anytime there is hypothyroid, decrease in the thyroid gland itself, or in the thyroid hormone, excuse me, what is that now decreasing along with that? What is the issue with hypothyroid? Metabolism, very good. So now, again, we're going back to the exercise person, okay, where we're having a decrease in metabolism. The body is now focused on that, okay, that the fact that it has a low metabolism. Metabolism slow, which means everything else is going to slow down with it. So which means that all the hormones that's supposed to be secreted are going to be sluggish, okay? And if the hormones that are being secreted are sluggish, this now puts this person at a state of amenorrhea. Okay, so again, not to repeat, but going over some more things. So adrenal, so adrenal glands, hyperplasia of the adrenal can cause this also. Ovarian, yes, we know ovarian because this is where the estrogen comes from. So yes, ovarian failure, polycystic ovary syndrome, and so forth. And even some vaginal issues as well. Okay. I like this chart because it shows you, and not that you have to memorize this whole thing, because I know it's like a lot, but just try to go over this just to get an understanding, and it'll come back to you from your physiology, okay? So this is really nice because it goes over all the different endocrine organs, okay, and the issues that can come from that. And again, this is all due to either a lack of a hormone, okay, that's not being secreted that causes these particular issues. Secondary causes, again, they kind of give the same thing here. Hypothalamus, we talked about, anorexia nervosa, strenuous exercise. Something called pseudocyesis. I'm not sure if I'm pronouncing that correctly. But this is when this term is considered false pregnancy. Okay, this is a term that is considered false pregnancy. So what does that mean? That means that the body actually will, female's body will go into a state of not having a menstruation and will have signs and symptoms as if they're pregnant, but there's no fetus. Okay, so they will actually go through all the hormonal changes that they're, as if they were pregnant, but they're not. Okay, systemic disease, tumor, post-pill amenorrhea, that can happen, okay, after getting off of the birth control pill. Birth control pill, as you know, kind of tricks the body into thinking it's pregnant. And by the way of having these hormones balanced to the point where it will, yes, now shed the lining, but it's almost like a false shedding that happens. And even sometimes with being on a birth control pill, as you guys know, that sometimes females don't get their cycle because even with the increase of progesterone levels, yes.
So what's the long-term effect of taking the
birth control pill?
Is it going to affect their ability to get pregnant later? Or?
Yes, it will. They have done studies with it. Yes, it will, because it's a catch-22 with the birth control pill, because it is a very good cure for ovarian cysts. It helps with, because the thing is, the birth control pill balances the hormones. So it's very good for situations where females have issues with menstrual cycles, ovarian cysts, types of situations. But long-term for fertility, it's not a good idea, because it is tricking the body into having this hormone level that's not real, if that makes any sense, okay? So then now your body has to kind of cleanse itself from being on the birth control pill from however many years, okay? And then now kind of get back into its own normal routine, okay?
I think they've also used, this has actually happened to me because I couldn't get pregnant for 3 years. They actually recommended me to be on birth control for a couple of months, not long term, but to see if that would help the pregnancy as well.
Right.
So they use it as short term
Short term to kind of balance out the hormones.
hormones.
Well, they should have just gave you progesterone.
Yeah, but it was like there was a lot of options,
Okay.
but I think that's what they also use.
Keep in mind too, and I'm currently taking because my hormone levels are off, and they do have natural things that you can take to increase your own natural progesterone and your own natural estrogen. So the naturopathic doctors, they have all different kind of tinctures and things that they can make up. So there are natural ways of treating this too. Okay. So pituitary gland, as we know, again, can definitely be an issue, again, not being able to secrete the hormones that we need to. Okay, so this is just repeating thyroid, adrenal, okay, you can read through that, ovarian, uterine, intrauterine pregnancy. This can also cause amenorrhea. Trophoblastic disease, I'll explain what that is. Trophoblastic disease is just a term for females that have lesions inside the uterus. So they'll have lesions, or sort of like, I'm sorry, let me get the right terminology. Adhesions, not lesions, adhesions in the uterus. Trophoblastic disease is adhesions in the uterus. And then ectopic pregnancy, you know what that is. Okay. Now, the next one here is Menorrhagia. Between. Okay, so this is bleeding between periods or menstrual cycles. The cause here, they say slight bleeding for the endometrium during ovulation. Any type of malignancy that happens in the uterus. Okay, so even sometimes polyps, fibroids, even let's say endometriosis where the lining gets thick. So anything like that can cause this sort of intermittent bleeding. So any type of, I would say, disruption to the uterus. Estrogen therapy, increased estrogen therapy. When estrogen levels are too elevated, it can cause this extra bleeding. Okay. Hypomenorrhea. This is deficiency in the amount of menstrual flow. Okay, so what happens here, this is where the hormones are actually shedding the lining of the uterus, as what it's supposed to do, but it now is an issue with the amount of flow that's occurring. They do say that this can be endocrine, but most of this has to do with some sort of partial obstruction in the reproductive organ itself. Okay. Oligomenorrhea is infrequent menstruation. Infrequent menstruation. And this comes from endocrine systemic order that causes the failure to ovulate, causing this infrequent menstruation. So what happens, if the ovulation cycle is off, this is going to throw off the whole menstrual cycle. Okay, so does everybody understand that? Okay. Now, menorrhagia, this is increase in the amount and duration of bleeding. So this is, we can say, more of a heavy flow, so to speak, or increasing the amount of blood during the menstrual cycle. Okay, and the causes here can be lesions of the reproductive organs. And we're going to go into this again when we talk about endometriosis. So please understand that this can happen from, say for example, if a person has fibroids, okay, so the tumors inside the uterus or around the uterine wall, even sometimes lesions inside the uterus. So any type of extra scarring and things like that can cause this extra sort of bleeding. So, abnormal, dysfunctional uterine bleeding can be tumor, inflammation, pregnancy, a lot of different things. Keep in mind that most of the times these patterns are pretty much, they say common here, but they also see them like in the beginning of when a female or the girl first starts her menses to even when menopause. So usually that you will see young girls that will be on the birth control pill or what have you to try to regulate the cycle, because in the beginning it'll start off that way, okay? Menopause, we know what happens with that because everything is decreased, so everything slows down, okay? Now with menopause can be tricky, okay? And I will tell you this, because the hormone levels are decreasing as we know with menopause, so the uterus is shrinking, everything's slowing down because it's time to slow down. But keep in mind that it goes through phases, okay? And I don't know if you've heard of this, but I've actually heard of 2 incidents with this where females have become pregnant during menopause, okay, or as they're going through menopause. Because what happens, they feel like, okay, well, I'm not getting a cycle, think you're good to go, okay? But the problem is that the hormone levels may elevate at some point to where the uterus is still now nice and healthy. They still have good enough progesterone to coat the uterus and coat the fetus, okay, for implantation. So then, therefore, they'll get pregnant, okay? So that can happen. Now, adolescents, again, if they do have issues with the cycle being off, this can be, again, from more of a hormonal pituitary situation. Perimenopause, we know what happens with that. The ovaries don't produce enough estrogen, decreased estrogen, therefore everything starts to slow down. Dysmenorrhea. That's the last one. I know it's time to talk about menorrhagias. Okay. Dysmenorrhea, this is the last one. This is painful menstruation, okay? Painful. Yeah, they're all painful. I know, and it's funny because you look at this, I'm like, this is not really a disorder. Okay? But even though we want it to be a disorder, have a day off, that's not the case. Now, keep in mind that we all know, going back to physiology, that when menstruation happens, we know that it sludges off the lining of the uterus. Okay, so we all know that, the endometrium of the uterus. Now, keep in mind that there's a contraction that happens in the myometrium that causes this lining to come off. The contraction of that is what gives the female its cramps, the cramps, so to speak, because of the fatigue of that muscle, because it's constantly contracting to get the lining off. Now, this is what they're calling painful menstruation, okay, because they're saying that the constant contraction of the myometrium giving all the pain in that region. And as we know, this pain, it does not stay in the abdominal area. It can, the pelvic area, can actually radiate and go different places and cause back pain and all kind of stuff. But this is what they're calling painful menstruation. Now, they do say that there are some causes, and the reason why I guess they're considering this a disorder, because sometimes it can get very severe. I even had a girlfriend one time. She had very painful, her menstruations were crazy to the point that she would even faint. So that can happen. So sometimes people do have a disorder in that sense. So primary, it does develop 1 to 2 years after menarche, right in the beginning. Okay, so this is again more of a pattern that happens right when the females start their cycle. The results from an increase of prostaglandins that promotes the uterine contraction. So prostaglandins will actually cause these uterine contractions to just kind of increase or elevate. Sharp suprapubic cramping severe enough to limit activity, nausea, vomiting, and diarrhea. So it can be debilitating to that point. Okay. Secondary, they say associated with pelvic disorders such as endometriosis and any type of adhesions. So obviously if a person has endometriosis or even fibroids and things of that nature, they do have painful menstruations, as you can imagine. Okay. So the treatment here is prostaglandin inhibitors. So if we inhibit the prostaglandin activity, as we know, this is going to relax that contraction of the uterus, of the myometrium in the uterus. Okay, so therefore, relaxing that whole situation. Oral contraceptives are given to balance out the hormones. Okay, so it'll calm down that whole situation. And they will do also surgery to take out any adhesions that are there. So if the adhesions or the fibroids or whatever the cause, they have to treat the cause with this. Okay, so that's that. Now we're getting into the fun stuff. Okay. So I'm sorry, but I will be showing you some gross pictures that are coming up. Yay, some people like them. Yeah. Before I get into this, I will tell you a story, okay, to open up with this. I used to work in the OBGYN office, and you guys will probably experience this when working in females, especially older females. The older ladies, and when I say older ladies, I'm talking about geriatric community ladies, will call the office and say, I need help, I see something coming out. Okay, and I'm not trying to be funny, but this is the calls that we used to get in the office. And so what happens is that as with aging, as we know, the uterus is held by a lot of different ligaments. And just like the normal aging process, unfortunately everything goes south. Okay, so what happens is that the ligaments will get lax, and they will get lax around that area of the uterus. Remember, the uterus is only suspended by ligaments. Okay, it's not held to the abdominal wall at all. It's not retroperitoneal, it's not stuck to the wall, it's just held by ligaments only. So when those ligaments get loose or lax, it will cause the uterus and all of the contents that are in that, well, the uterus to drop into the next organ, okay, which is the vagina. So the issue here is that when females get uterine prolapse, there are some causes of it. Yes, age is one definite thing, but also multiple pregnancies. So the more babies that a mom will have, it can weaken the ligaments around that area, obviously, as the uterus stretches out even more and more. And I think that's the only two risk factors I think. Okay. So uterine prolapse. Prolapse is sinking of the uterus from its normal position into the vagina. Okay. One thing I just want to clarify, and hopefully you'll remember this. In anatomy, when you look at the female reproductive system and you have uterus, cervix, and vagina, okay? Now, usually in the doctor's office, they usually say uterus, cervix, and vagina as if it's three different organs. But keep in mind that the cervix is just the lower portion of the uterus, okay? It's not a separate entity, it's just the lower portion. So what happens here is that when we have uterine prolapse, the uterus actually will drop through the vagina. So it's the cervical portion of it that will drop down, okay? And then you'll get the full, I'll show you a picture in a second. You'll see exactly what I'm talking about. Okay, so it's the whole thing that drops down. Okay, so results from a relaxation of the pelvic structures, again, the ligaments and the cervix. So this, they say it can occur at any age, although most commonly with geriatric and people, females that have multiple children. Congenital defects, pregnancy, childbirth. Okay. So, I'm sorry to show you this picture, but you may see it. Uterus.
That's just swollen.
No, it's not
So
swollen.
that's just the way.
That's the uterus. Okay. Uterus, cervix. So you understand what I'm saying? So this is uterus and cervix all together. Okay. So please keep in mind that there are different degrees of uterine prolapse, okay, and they can be detected. And believe me, I was told to go over this with you guys because you guys, from my understanding, when you go into OBGYN and peds, whatever, and yes.
Is it painful?
It can be painful to feel like pressure, from my understanding.
Pressure.
It'll feel more like pressure. Now, obviously, the more of a prolapse, it would be more painful, but it feels more like pressure from what the ladies will call in and say. I feel something pushing out, yes.
The urinary bladder does that too. We see that a lot where the bladder actually
Yes,
comes
this is
out.
Lucilla Rectocele. I'm actually gonna go over that next. I have pictures of that too. Yeah.
So now this will cause a higher increase of like bacterial infection, right?
Oh, yes. Now, as you can imagine, that situation will, yes, increase infection. Okay, so there can definitely be a high increase of infection. Now that is usually, that's an extreme case, okay? Usually when it's detected, when they'll feel just like the beginning, like a first degree. That's more of an extreme case, but I don't know how but that's more of an extreme case. So first degree is when the uterus is halfway between the vaginal orifice and the level of the ischial spine. So this is just a little bit. Second degree is the end of the cervix begins to protrude through the vaginal orifice of the introitus. Third degree is a complete prolapse, which is what we saw in the picture. Okay, so that was the entire body of the uterus, okay, along with the cervix and everything out. So these are the positions. Please make sure you know the description of each position. In this particular picture here, I may have on the test, okay? This is in your book. I'm not going to have that other picture, but just this one, okay? So one of these positions, okay? So make sure you know the positions because you would have to grade them, yes.
Final, right?
Final. We're done with weekly tests. So everything that I'm covering today is for the final. Okay.
Is most of the final going to be whatever most recent?
No, it's going to be a mixture of everything, unfortunately. It's going to be, no, it's going to be 100 questions.
Oh, Lord.
The final's 100 questions.
Essay?
No.
What?
Everybody's going to jump on you.
What's that?
Who said that?
No, mixture from the beginning, first week one. Week one. Your final is kind of like what I call an exit exam, okay? Because we want to make sure that you know all this prior to the final grade exam. Okay. All right, so we're good with that. Now, so make sure you know, again, please make sure you know the different degrees. I will test you on this. With this,
I can't read
pubic symphysis. Pubic symphysis. Now, depending on the severity of prolapse, you do have the signs and symptoms. So as you asked the question before, is this painful? Okay. Yes, depending on how much of a prolapse it is. They can have a sensation of fullness, pressure, vaginal discomfort, obviously discomfort sitting and walking, okay, with that going on. Difficulty urinating, yes, okay, because this is now disrupting the urethral orifice as well, okay, if you have that much pressure on the vagina. They can have bleeding, ulceration of the cervix from friction, so as you said, they're definitely now leading them into infection and things of that nature. Treatment, they say, is hysterectomy, but the most common treatment that I saw when I would use, because I used to work in a GYN office and we saw this all the time, is pessaries. So pessaries, when they notice that the females have this laxity, okay, and so they'll usually catch it at a first degree, and they will fit them for a pessary. So a pessary just kind of looks like a cervical cap, if you've ever seen, okay, what that looks like. It is a form of a birth control or barrier, okay. So it looks like a cervical cap, but they'll put it there to kind of hold up the contents of the uterus.
Is that like what they're calling now the slings? All those little slings? Is that for the blood or is that for blood?
No, they don't call it a sling. That I think is more of a bladder. Yeah, that's more for the bladder. This is something different. This just looks like a little cap that you just put.
Does this have anything to do with like transvaginal mesh?
I'm not sure what they use. I don't know if they use transvaginal mesh for this, or if they use transvaginal mesh for. Is that more of a birth control transvaginal mesh? I'm not sure what that is.
I don't know.
See the commercials.
Okay. I think the commercial is more for. I think that's more of a birth control, from my understanding.
They're doing a recall.
They're doing a recall.
On a mesh. Big giant cross section.
Oh, well, maybe it is something like that has to do with this. I have to look that up. I just know it as a pessary. Maybe it is the same terminology, but I know it as a pessary. I'll have to look that up. I'm not sure. Retrodisplacement of the uterus. This is when the body of the uterus is displaced, okay, and in a different location. So normal anatomy, do you remember what does the uterus, how is it in the female? Is it flexed? Is it straight up? Is it lying down?
I would say a little bit of an angle.
Okay, very good. It's on a little bit of an angle, more flexed position, okay? Now, sometimes the uterus can be hyperflexed, okay, or flexed more towards the anterior, more towards the posterior. So keep in mind that at any point that the uterus gets out of its normal position, this can pose obviously issues such as what? What kind of issues could this pose if the uterus is out of its normal placement?
Infertility.
Infertility, not so much infertility, but in the sense of problems with labor and delivery. Okay, so even the female may be able to get pregnant. Okay, but it can pose a problem with the growth of the fetus. Okay, in the uterus if it's flexed or in one position or the other. So this can definitely cause issues with also the growth of the fetus, but labor and delivery. So when it's time to deliver, that can cause a lot of issues. Okay, so they say that this is very common, okay, can be detected in 20 to 30% of women. And this is common, I do remember this kind of situation as well. And it may be present throughout the woman's life or develop after childbirth. Now, sometimes this can be something that the woman just kind of lives with and it's okay and they can still deliver normally and everything's fine. Or sometimes it can pose an issue. Okay, so I don't want you to feel that it's something that is always an issue. Okay. Causes here can be congenital, you can be born with it, pregnancy, childbirth. So even again, multiple pregnancies, multiple childbirths can now cause the uterus to kind of move and shift, okay, and go into a different position. They have 5 positions here, and I do want you to know the 5 positions. This is another picture that I may put on your test for the final. So, wait, I'm sorry. I'll show you the picture in a second. Anteverted, mid-position, anti-flex, retro-flex, and retroverted. Okay. So signs and symptoms, most women do not have any signs or symptoms with this. Most of the times they don't know they have a flexed uterus until they go to the doctor and have an exam done and they say, oh, don't you know your cervix is flexed or tilted or anteverted, and you know, they'll give them all these names and they didn't know, okay? Or when they do know, depending on the severity of it, they can have pain, pressure, changes in urinary flow, and also changes in sometimes their menstrual cycle. Okay. No treatment if no symptoms, but if there are symptoms, they will give them a pessary to kind of hold the uterus in place. Okay, so again, that pessary comes back.
So which, on those illustrations, which one would it be
With chair,
most aligned with a normal uterus slant?
out of this picture.
Yeah, I wish I could see it the way it's supposed to look.
Okay, mid-position is more along the lines of normal. Okay, but they're calling it mid-position because it's weird. Mid-position almost looks normal, but it's supposed to be just flexed, just tilted just a little bit back. Okay, so if you know that vagina and uterus is more like at a right angle, okay, so kind of like a 90-degree angle. Which is important to know, I guess, when you guys do GYN and, you know, do the GYN exams, that this is supposed to be more like an angle. So the uterus will sort of, this should be lined up to be almost 90 degrees, so to speak. Something like that. So it should be